around me means nothing to me if I can't share it with you. Walking through all the dust, memories and frame, a past we simply let fade. But I don't close the door, waiting the chance for when we'll be back again. You make me feel so crazy, still in love with you. You make me feel amazing when I'm next to you. You make me feel so crazy, my heart breaks for you. Can't help but knowing that I'm still in love with you. You make me feel so.
Hello and welcome to Neobiotech International Virtual Seminar. Thank you for attending this webinar, and my name is Chi Hun Shin. I'm going to be your host tonight. Before we start today's webinar, I would like to briefly introduce about schedule in this month. Today's lecture will be by Dr. Jeffery, as you were informed. Next week, Dr. Manuel Fragrino from Mexico will present the lecture in Spanish. On 22nd, Dr. Giuliano Galani from Italy will be with us in English. On 29th, which is the last term for July, Dr. Murad from Jordan will present the lecture. We would like to welcome you all anytime. Please be advised that there is no translation service in different languages other than the lecturer speaks. Please notice that all the lecture schedule is based on GMT hour, as Greenwich Region time in England. So you will either be informed by your distributors or managers, or you just need to Google to figure out lecture time in your time zone. All right, for tonight's webinar, Dr. Jeffery from US will speak about how to predictably place and restore implants within days of each other. He will kindly share his experience and knowledge for about how long. During the webinar, if you have any questions, please use the chat button to communicate with me about any issues other than the topic. We'll have Q&A session after the lecture, so please submit your questions through Q&A button. Dr. Jeffery may not answer for all the questions because we have limited time to take answer for all. If you have more questions or anything for discussion, you can contact Neobiotech website, which is neobiotech.com, or find Neobiotech Global Department on Facebook. So now, let's have Dr. Jeffery to start. Please welcome. Hello, Dr. Platt. How are you tonight?
I am joyful. How are you doing today?
I'm doing good also. Thank you.
Great. Excited to be here with everybody and excited to have you all here for this initial international webinar that we have. For this evening, what I would like to do is to begin by mentioning and viewing with you and talking with you a little bit about a couple of things. And so first thing I'm going to do is let me share my screen with you and bring that up. And then from this, we'll begin to introduce our particular seminar itself and the topic that we're going to place and visit with about today. This topic is one that I'm passionate about. I've been placing implants now for about 30 years. I am a general dentist and enjoy doing everything as a general dentist. but particularly part of my passion is with the surgical aspect of things. Not only is this something that is that I appreciate about this particular company, I've lectured for other ones in the past, and I am currently right now preparing to receive an implant in my mouth. And of all the implants that I have been associated with over 30 years, many of those companies are still available. But right now I choose by my own choice to prepare my mouth for a Neobiotech implant. And so that will be something that will be part of my lectures here shortly, will be in my own mouth and showing that. Let me tell you why, and today I would like to share with you why I would choose this particular company and this particular implant to place in my own mouth. And one question that I think is a valid question for any lecture is, would you put this in your mouth? Or would you put this in your spouse's mouth or your children's mouth? And so my answer to you is yes, I would. Let me tell you, as we go through this, this lecture today, I am hopeful that you'll be able to see why I would choose to purchase and to pay for this implant to be placed into my mouth. Not that somebody's going to do it for free, but to have this implant placed with me. And so we'll do this, and we'll go over that today with you a little bit. So let's begin, shall we? Traditionally, as we look at placing implants and prosthetically restoring them, we have these options of when we would load our implant, when we would place either a temporary or when we would place a permanent restoration onto our implant itself. What we would like to introduce today, the topic from this particular implant company of Neobiotech, is that we don't need to be using a delayed loading. We don't need to be using the terminology of early loading. We don't need to be using the terminology of immediate loading or conventional loading. But we need to use a new terminology, and that is anytime loading. We'll let you know a little bit more about what that means, but essentially, anytime loading means that you as the surgeon or as the restorer can predictably know when it is appropriate to place a temporary on an implant or to place a permanent restoration on the implant. And with anytime loading, the choice of when to place the prosthesis onto your implant is going to be determined by you. We're going to talk about the science of that. We're going to talk about a way that you can use technology to check and make sure that you are loading your implants appropriately, that you're going to have success with that, and you're also going to do it with current technology and current principles. So first, let's review a little bit. Implants were introduced by Dr. Brannemark, and in studies that were done in the late 70s and 80s, particularly by Dr. Brannemark and by Dr. Albrechtsen, they determined that following the placement of the implant, that a surgeon or a dentist should wait for 3 to 6 months to allow the implant to heal before looking at placing the prosthesis on that implant. This was their initial recommendation that they had 40 years ago. 40 years ago was where this came from. And so my question to you is that still valid data that we should be using? Should we still be using data that's 40 years old as we consider what we should be doing in the year 2020? My suggestion to you is that there was a lot of things that happened back 40 years ago in the 1980s that were good in the 80s, but right now they're kind of outdated, and we don't particularly use things and do things. Show why we would consider placing an implant, and studies that Dr. Hall has done that would illustrate the success of this particular implant system, and also success of the implant being placed in a variety of areas. There was, in this particular study, there was over 1,000 implants that were placed. And these were placed in the maxilla, in the posterior area, in a class 1 scenario where the implant was not engaged in the sinus. a class 2 scenario where the implant was placed just into the cortical plate of the sinus, as well as the cortical plate of the crestal area, called a bicortical plate stabilization. There was also a class 3 implant that was placed where there was a crestal approach sinus lift that was done, and then a class 4 implant where there was a lateral window implant and sinus lift that was performed. In these, there was a 98.5% success rate. The next study that we'll talk about was an area that over 2,600 implants were placed. These implants were placed throughout the mouth, in the anterior, posterior maxilla, anterior and posterior mandible. And again, over 2,600 implants were placed. And what I want you to remember is this particular number right down here, 99% success rate with that. That's not something to just be set aside, but you're going to notice as we begin breaking this study down and show you why and where this 99% success rate came from. So let's consider other areas. And so of those 2,600 implants that were placed, there were 960 that were immediate placement implants. Of those immediate placement implants, again, success rate down at the bottom was 99%. The next category that they were broken down into, or that composed part of those 2,600, was the delayed immediate placement of an implant. Again, if you look at the success rate of that, of those delayed immediate placements, 99% is the average of those implants that were placed. An immediate loading of those, 510 of those implants were immediately loaded, and success rate of those throughout the mouth was 99%. As we considered early loading of the implant with either a temporary or a permanent prosthesis, again, 99% success rate was established throughout the mouth. The maxillary sinus area, which typically is going to give us the either D3 or D4 level bone, which technically is probably the poorest quality bone that we can have that for us to play. In that particular maxillary sinus area in the posterior, again, a 99% success rate with that. 431 of those implants were immediately loaded or early loaded in the sinus area. And again, what is our success rate that Dr. Hall was able to receive was, again, 99% success rate in that area. Another study that was done with Brandemark implants. This was a 10-year study that 384 Brandemark implants were placed, 118 patients. They were placed in, again, similar areas, in the anterior area of the mouth, in posterior, in maxilla and mandible. There were single implants that were placed. There were full arch. There were multiple implants that were placed. And from this study, this is where some of the information that we currently are using with many implant companies as far as how we're going to restore our implants comes from. And so part of this study showed that in the unilateral posterior area of the mouth, where where implants were placed, and then where prosthesis was placed, either temporary or permanent, it was determined from that implants should be either together in order to stabilize that prosthesis and to stabilize implants. That there should be more than 3 implants particularly that are put together. And as we splint and stabilize 3+ implants together, then that's going to create a scenario.
Dr. Platt,
Yes, sir.
I have to interrupt.
Yes.
May I ask you to turn off your video since everything else is lagging a little bit? I think that's the video data is too much for your Wi-Fi system.
Excuse me, let me do that. All right, let's try that and see if that's a little better. Thank you. Let me know if that's not, okay?
I'm in your camera to show your face. Can you turn the screen off?
How about that?
Sure, I don't see you. Thank you very much.
All right, we'll try that and see if that's a little better. You can still see my screen though, correct? All right, so with these Brandemark implants that were placed, these are follow-ups of the implants that were placed in '99 and then throughout 2016. And again, as you noticed, they were splinted together. And as they were splinted, there are a minimum of 3 implants that were placed. And those 3 implants that were placed created a scenario where they were stabilized. In the continuation of this, hang on just a minute. I'm going to stop sharing just for a moment. And restart from that slide because that one stopped it there. All right. So from that, there was created what we term in implant dentistry now as a stability graph. From the stability graph, this shows what the osteotomy does when the implant is initially placed.
Sorry, Dr. Platt, I have to interrupt again. I don't see your screen, your presentation.
Are you seeing it now?
Yes, Jim? I do.
Okay.
Thank you.
Thank you. Still seeing it, Shin?
Yes, I do.
Great. All right. Thank you. So with our stability graph that we have that was created from the Brandemark study and from Dr. Brandemark and Albrechtsen and company, the process of the implants that were placed created a stability curve for our initial bone or primary stability of that bone that starts off and then over time, the primary stability or the old bone begins to lose its ability to hold our implant. At the same time, when the implant is placed, there is new bone that begins to form around our implant that is called a secondary stability. This creates a scenario where there is a stability dip between growth happen faster. And in doing so, could we actually eliminate our stability dip that we would have and create total stability throughout the life of the implant during the first 8 weeks? In order to do that, there has to be a change that happens with our implant. We have to change a few things. We have to look at things differently than we have before, according to what we have been taught in the past. and we have to be able to make changes to an implant so that that implant will not only just fit into the osteotomy site, but that it will fit ideally and perfect so that the bone will begin growing and hold and fix that implant in place from day one. And so in order to do that, there are some changes that need to happen with the way that we place an implant. This is a physiologic placement that we have to consider. This placement or this osteotomy that we are now going to make, it has to be a different osteotomy than what we are used to doing in the past. We have to be able to look at fixing this implant in a couple of different areas. We also need to look at the surface of our implant and the threads of our implant. And by doing that and approaching our implant in a different way and from a different approach, we're able to now create a scenario where this implant is going to integrate almost immediately from the beginning steps of that. And then this implant is going to be fixed and stable enough that we could then load this implant anytime that we wanted to. Let's consider first the design of that and the fixation design, what we want to do to our initial osteotomy itself in order to create a scenario where this osteotomy is going to be as close to ideal and as close to perfection as we can allow this to be, so that our implant will begin to osseointegrate almost from the beginning moment that it's placed. Dr. Ha has introduced to us what is called CMI fixation. And in that, what he is, there are 3 areas of our osteotomy, or 3 areas of our implant that will show you in the osteotomy that we need to pay attention to. There is a crestal or a coronal portion of the implant and of our osteotomy that we need to pay attention to that. And we need to prepare our osteotomy to fit in the crestal area different than we need to into the middle area. Bone in the crestal area, bone in the middle area, and then bone in the apical area of our osteotomy need to be prepared and need to be considered differently as we place and as we create our actual osteotomy itself. And so the CMI fixation goes to show that in the crestal area of our osteotomy, that we need to do things different there, where we are supported, or where the implant is supported by cortical bone. Cortical bone, as you know as well as I do, has minimal blood supply to that. The middle and the apical portions of our osteotomy typically have a higher blood supply with them. And so in order to approach the osteotomy in the middle and in the apical areas, we're going to have our preparation be a little bit different in those areas too. Let's show you a little bit more illustration of what that would mean. If we are looking at D3 and D4 bone with our actual osteotomy that's going to be performed, as we go through the cortical plate and into the medullary space, we're going to create our osteotomy there, and then we're going to prepare our coronal or our crestal area of the osteotomy so that that will fit our implant in the design of that a little different. We want the implant to fit passively in the area where the coronal aspect of the implant is being placed, or of that osteotomy. We also want to have some self-compaction in the middle and the apical area of where our implant is being placed. In our posterior maxilla, we want to have in our CMI fixation, in a class 1 implant that is being placed, we want to have the cortical area being taken care of, and we want to have compaction or compression of the medullary bone itself. In a class 2 implant that is being placed in the sinus, we are going to have a bicortical plate stabilization of our implant. And then we're also going to have compression or compaction of this medullary space in order to fix our implant and to get our implant into a stable area and scenario. And so in this particular scenario of a class 2 fixation, the osteotomy is created. The implant is inserted, and if you remember, we've got our cortical area or crestal area that has been prepared so that the implant will fit ideally there. We're compacting or compressing our medullary bone, and in the apex or in the sinus area, as that comes and penetrates through that cortical plate in the sinus, we're going to have a stabilization of our implant throughout the crestal, the middle, and the apical area of our implant placement and of our osteotomy. And so as we consider this, the area where we're going to have contact with bone in our osteotomy, in a class 1 scenario, we're going to have contact of bone and implant throughout both the crestal, the middle, and the apical portion of that implant in both a class 1 and a class 2 scenario. In a class 3 scenario, where there is a crestal approach sinus lift, we're going to have contact with bone in the crestal and middle area of our implant. In the class 4 scenario, where we're doing a lateral sinus lift, and there is minimal amount of bone in the crestal area, that is the only area that we're going to have contact with native bone. The rest of the bone is going to be from a bone graft scenario that is placed. And so as we consider fixation, is there an area of our osteotomy that is better or that is more important in our fixation process? Is there an area of our implant, whether that is in the crestal, the middle, or the apical, that is going to create stability enough that we can anytime load our implant that we need to consider? And I would suggest, yes, there is. The way that we know this is if we begin applying a lateral force to our implant. And this lateral force that is being applied to our implant will then at that turn translate our force upon the bone in the area where the implant is being placed. There is a lever arm that is created by the force that is being placed upon our implant. And so in this scenario to the left, if we are applying force here, that lever arm is transferring that force throughout the crestal and middle area of our implant. In this scenario, this force that's being applied is translating and it's changing the force so that it is only being translated in the apical portion of our implant. That is a weakened area, and it would not take a lot of pressure in order to move this implant when it is only fixed in the apical portion. What about if the implant has a fixation in both the middle and the apical? If we apply a force, that's going to create still some movement that's going to happen with our implant. In an area of an extraction socket like this, applying a force is going to translate this lever arm into an area that the implant is still going to be located and fixed in the middle and incisal, or the apical component of that. And so what we would suggest is that there is an area that is most important to be considered for loading our implant and for any time loading our implant. And that area of most importance for stress to be concentrated is in the crestal portion of our implant and of our osteotomy. This is the area that we need to pay the most attention to, is that crestal or component of our osteotomy site, so that we will not compress or compact that bone that has minimal or little blood supply to that area. Also, Dr. Hall has suggested that as we consider insertion torque of our implant, how much torque should we place, and also how much, what should we do when we have a minimal amount of torque or insertion torque that is present with our implant? Studies would show and suggest, and Neobiotech would recommend, that if you only have 10 to 20 Newton centimeters of insertion torque on your implant, that implant should be completely submerged and should be buried underneath the gum tissue so that it can heal appropriately. If you have 20 to 30 Newton centimeters of insertion torque, at that point, you may consider placing a heating abutment on that, or you may even consider loading the implant. If you have 30 to 40 Newton centimeters of insertion torque, then that is an implant that you easily may be able to consider initially loading or immediately loading or anytime loading. Another thing that we would point out and suggest is that we should not be exceeding 40 Newton centimeters of insertion torque. If we are exceeding 40 Newton centimeters of insertion torque, we are going to be compressing our cortical area of bone. And if we are compressing our cortical plate, we are going to be causing and allowing pressure necrosis to happen. And we will show you what that does. This is an illustration of what pressure necrosis looks like in an implant. And from a study that was done, this is an area where compression necrosis would happen on the crestal area of our implant. And we would see dieback or death of bone in this area because as the implant was placed, there was either the insertion torque was exceeded or the implant itself was placed in an area that caused the threads or the actual implant to place too much pressure on the cortical plate and thus allowed this area of the bone to begin dying. This is what illustrations would look like if you were to come back into this implant and look at the bone. You would see death of the bone around this particular area of the implant. And so compression necrosis is a result that happens when we have too much pressure that's being placed in an area or the cortical area or crestal area of our implant. And we have to be careful with that. It creates part of a dilemma. The dilemma is if the crestal area is the most crucial area, which I would suggest, and so would Neobiotech, that area is the most crucial area of our implant and of our osteotomy site. What would happen if we have overcompression of that area and of the bone? And if we do overcompress that as we're trying to stabilize our implant, we're going to cause necrosis of that. So we have to do something different to that area of the bone than what we have been doing in the last 40 years. That's what we're going to suggest to you. So let's look at scenarios here of how we're currently placing implants. If the current implant that you're using is a self-tapping or self-threading implant itself, which the majority of implants that are currently out there are, this is the scenario we typically go through in placing a self-tapping implant. The osteotomy site is created, and then from the osteotomy site that's created, the implant is essentially screwed into the bone. As that is screwed into the bone, the threads create the tap, or the threads create the area of contact with the bone. Now, with our self-tapping implants, where are we having a lot of pressure? We're having too much pressure in the crestal area. And so in this area here, where we have little blood supply, we are now compressing that blood supply or shutting that blood supply off with our self-tapping design. In another illustration of our osteotomy that we are creating, we might be able to do a countersink drill and use a countersink and self-compaction combination. And so in this scenario, we're creating our osteotomy site, and then we're also creating a little bit of an extra space here for our threads. This is heading the right direction, but it's not quite there. There's still some things that are missing. And the things that are missing is that the threads of the implant are still having too much contact right here with our crestal area of the bone. And if we have too much compression and too much contact with our threads, we're going to allow that area to cause pressure necrosis. This is a scenario that we're suggesting for any time loading, that as we prepare our osteotomy, that we need to be careful and we need to be precise in our creation of our osteotomy. And so we would have a typical scenario that we would create an osteotomy, and then from there, we're going to use a tap drill. A tap drill essentially creates thread space for the implant to come into. And so the tap drill is going to remove bone so that the threads of the implant may now fit in ideally with the bone without creating pressure from those threads being placed onto the cortical plate or onto that most sensitive crestal area of our implant. And so as we begin placing our implant, the implant is now going to fit ideally and almost perfectly into the crestal area, and we're going to be protecting this area of our bone. This most crucial area of our osteotomy site is going to be as close to ideal and perfect in the form and shape of our implant, so that the implant will be inserted into this area without having any compaction. This is the area, the middle and the apical area is where we want to have self-compaction of our implant, not in our crestal area. And so this is the form of our implant and of our osteotomy that we want to use. Now, not always do we have a cortical plate. Oftentimes in a D4 scenario of bone, we may not have a cortical plate that will be there, or that cortical plate may be 0.5 millimeter or 1 millimeter in size. If we have almost no cortical plate that is present, this is the scenario of how we would go about placing an implant with self-compaction in D4 bone. This is the scenario that we currently use for all of our level of bone that we do, where we're going to have self-compaction of the entire osteotomy site with that. In D4 bone that is soft from the crestal component to the apical component, it is okay to have a self-compaction of that area, because that bone is all vital and has blood supply that runs throughout that. Now, in scenarios from either D1 to D4, where we have a cortical plate that is present, and that cortical plate that has limited blood supply, what we're suggesting and what we're going to show you is that in that cortical area is where we need to have a tap drill or a pre-tapping drill that is placed, so that that area will have passive fit of the implant, and then the middle and the apical area will have an active area of placement for our implant or compression. And so in using that, we're going to have a tap drill, again, that will be able to fit the thread design of our implant exactly. This particular thread design is going to allow the implant to fit in as passive as possible in areas where there is little to no blood supply that's present. And so the scenario in a D1 to D2 bone, we would have our osteotomy that would be created. And then from that, we would use our tap drill that would create threads for the entirety of the implant itself. Now, this implant is tapered in design, and as we start to use that, just the long tap drill itself, if you notice that the insertion torque is going to be exceeded in the last little bit. And in the last few areas that we're screwing our implant into place, if we exceed that 40 Newton centimeters, we are going to have and cause pressure necrosis to happen. And so there is both a long tap drill that is used, and there is also a crestal tap area for this D1 to D2 bone. And so the proper way that we're going to suggest and recommend that you use that is that you do use a long tap to tap the entirety of the implant, and then come back with a shorter tap for the crestal area of the osteotomy, so that there is not going to be a scenario where the total Newton centimeter of insertion torque is going to exceed 40 Newtons. In this scenario with D1 to D2 bone, the implant is placed and there is an intimate fit, but it is not a compressive fit of the bone. And that is important to understand in our D1 and D2 level bone itself when placing implants. So we've considered now our osteotomy site, and we've been able to create an osteotomy in a D1 or D2 level bone, a D3 and D4 level bone. And that osteotomy that we've created is going to create a fixation point for our implant in the bone to be intimately placed, and have that implant still be able to have compression in areas where we can compress, and non-compressible in areas where the blood supply is small. Let's consider for a moment our implant design. What do we need to look at or consider in the actual implant itself? traditionally, these are the threads of a conventional implant. And if you look at these threads essentially are in a V shape. And this V shape of the implant threads themselves are have been the tradition of what the implant thread design has been for a number of years and decades. If we look at applying a lateral force onto our implant in this direction, what is there that's present that would enable that implant to have resistance in the thread design? And with a V shape or with a traditional or conventional shape of our implant threads, there is nothing that will resist a lateral force. And so when a lateral force is applied to a conventional thread, that implant will have micro movement or micro ability for that implant to change its position. As that implant changes its position, then at that point, that implant is not going to integrate and osseointegrate. And so if we look at changing the shape of our implant threads and the shape and the size, that we have areas where the implant itself is going to have contact with the bone that would be resistive to lateral forces, and I'll show you that in just a moment, as well as areas where that implant is going to be able to have contact and not allow that implant to have any micro movement. And so again, as we begin placing a lateral force with our implant, there is the ability for that bone that is present to resist that lateral force, and the ability for that implant to not have any micro movement and micro change that's going to happen with that. And so the actual thread design is vital in looking at an anytime load. And so just because you create the osteotomy properly, if the implant thread design is not such that it's going to resist lateral forces and lateral movement, that implant is not going to be an ideal. That implant needs to also be changed in its design and in its shape so that it will be resistive to lateral forces that are going to be applied to that when somebody begins eating and chewing on that. And so as we consider this fixation process of placing our implant here and having the proper amount of thread design and thread pattern, we need to consider a couple of things also in addition to that. And part of that is the shape or the size of the implant. Traditionally, an implant has been a straight implant. What we have found in Neobiotech is that in using a tapered body, there are many advantages to a tapered body implant itself. Those changes and those advantages are listed here, but part of the main things that are enabling this is that by changing and doing less trauma and less drilling to our bone, we are causing less trauma to that. A tapered body implant allows the implant to be placed with less trauma than I would suggest or would recommend that a straight body would have. There is an ease of insertion of a tapered body implant and less chance of an implant being what I would term a spinner, that you would not be able to have the force of the implant and the bone actually making contact with each other as in a straight bodied implant. And so does a straight body implant have benefits? I would suggest that if our most critical area is, again, the crestal component of that, in a straight bodied implant, this is the area where a straight body is going to have the most concentration of forces is going to be in the crestal area. And in that crestal area, right here with our implant, if we're placing too much pressure on our cortical plate, we're going to have and create pressure necrosis in this area, which will lead to bone death. Back in the 90s, when implants were being placed, it was common to say that you could have 2 to 4 threads worth of dieback of bone, and having 2 to 4 threads of loss of bone was normal to have in the 90s. That scenario right now, if you were to say that you're going to have 2 to 4 threads of your implant that is going to not have bone supporting that, and that's normal to have, I think the majority of us would look at that and say, whoa, that's a bad implant design, and we need to consider doing some treatment for that in order to take care of the bone loss. And so by taking care of our crestal component of our implant, we're able to have minimal bone loss. Studies have been done and shown that with this particular type of implant design and even thread design, and by changing some of the crestal threads into micro threads, that there are some benefits with that, and having a minimum loss of less than 0.3 of a millimeter. And in less than 0.3 of a millimeter with the micro thread design at the most crestal component of the implant, that has been able to minimize, if not completely change the loss of bone at the crestal component or crestal part of most implants. What we're going to suggest is even better than that. And I'll show you in a minute another study that would show that not only is 0.3 of a millimeter of bone loss not good, but we'll show you that we can even get bone growth with our implants that we have. These are implants that have been placed in a variety of different areas. And over time of these implants being restored, you can see that the crestal component of this bone does not change. Now, yes, it's easy to handpick a few selective slides of, well, this is the best that the implant looks like. That's not what's happening here. And what I would suggest in my office in Colorado as I place implants, that I see this happening regularly and consistently with all of my implants, that I'm not getting bone loss around the crestal part of my implant. I'm having the bone that is present in my implants stay there. And I'm seeing that the integration of that implant is complete in its entirety. Enough that we can say right now that it is possible to improve this stability dip and to change that. And so by changing that and creating the new scenario, this is what normal looks like to me right now in my office. Normal to me looks like 0 stability dip. And right now, normal to me looks like the implant is placed and the bone at the original time when the implant is placed is the same at 0 or day 1 versus week 4 versus week 12 or more. We have an implant that needs to deal with that, and that comes from a variety of things. Let's look at the surface design for a little bit of our implant. In looking at the surface design of our implant, as we're placing our implant here in the proper way for the osteotomy to be created, we are having the tap drill that's being created, and the tap drill is giving us the passive fit in this area so that when the implant is being inserted, that we're having a proper placement of that. We're having proper compression of that in the proper areas that we need to have. Now, as we look at a couple of illustrations of this, this is an ISQ reader that would show the readings at surgery and then 2 weeks and 4 weeks, which traditionally is the weakest part of an implant. And if you would consider taking an ISQ reading at 2 and 4 weeks, normally you would see that that ISQ value is going to decrease. And traditionally, I have seen that in other implants that I have placed, and other implant systems that I have placed, I would say. And typically, you're going to see at surgery, you're going to have a good level of an ISQ, but at that 2 to 4 weeks, you're typically going to see those numbers die down into the 70s or 60s. And then they will start to come back up to get back to the 80s as you move forward with time. And in this, you're seeing the ISQ values are staying in the 80s, and they are improving from where they began. So you have a final prosthesis that can be placed in a few weeks based upon when the gum tissue will heal and be appropriate for that. And that's really all that you're waiting for, is when do you want to have the gum tissue at its proper placement and proper ideal position for your implant to be placed. And even looking at 2 years later with this particular patient, you can still see that the bone around those original implants on the lower are having good position, that we're not losing bone, not seeing a lot of crestal area of the bone or dieback that's happening there. And so you're seeing good values that are happening. And what can normally happen in an immediate extraction scenario like this is that you can place an implant in an immediate and at 2 weeks see ISQ values in the 80s, and at 4 weeks deliver a crown, and then test at 8 weeks if you wanted to, and you'll see that the ISQ values are still high, with this. One of the advancements in technology that Neobiotech has been in creating this particular instrument that I love. This is an instrument that if it goes down in my office, I'm going to be crying, because this is an instrument that has revolutionized and has changed the way that we look at and gives assurance that our implant is integrated and is ready to be restored. Let me show you a couple of scenarios of how this would happen and what would happen with this. In using the AnyCheck has a little tapper that would come out the end, and this little tip of the AnyCheck has a component that will tap gently upon our implant or upon our healing abutment. There is also, as you notice in the video at the top left, there is a digital readout that happens. The digital readout gives us the ability to look at and to see how much integration has actually happened with our implant. In using this AnyCheck, this is something that I have taught my assistants how to use. And this is something that as the patient comes in for the follow-up visit of removing sutures, if we have sutures that are placed, or at any point along time, this is an instrument that the assistants can use to create and to register these values of the implant. When they see this and they take these readings, they will come and then tell me, as I'm working on another patient, what the readings are from the AnyCheck. And at that point, we can determine, yes, we're ready to move on. This implant is healed and is integrated, and we're ready to proceed. And so at 1 to 2 weeks, whenever you would remove sutures, you can check the integration of your implant. And at that point, traditionally, you're going to be in that stability dip area at the time that you're looking at removing sutures. That's the area where typically we are the weakest of our osseous integration. That is the time that typically we would remind our patients that you need to be careful. You need to not eat on this implant. You need to be gentle with this. We're not telling our patients that anymore with this implant and with this company. Instead, we're telling them just the opposite. When your gum tissue is healed enough that you're ready to eat and chew, if we have just placed some healing abutments there, we tell them just to brush it as soon as you're ready to eat over there as soon as the gum feels good enough that you're ready to begin eating in that area and getting food over there. I do not tell my patients that they need to be careful in eating and what they would do on an implant. Instead, I tell them, nope, as soon as your gum tissue feels good, you're ready to go ahead and treat it like normal. And in doing so, have confidence. And the AnyCheck has created that ability to have the confidence. Let me show you a couple of different things. So a couple of things that you need to consider in using this AnyCheck is that it has to have direct contact with the healing abutment itself. As you place that in direct contact with the healing abutment, you also need to see, this is, let me turn that off just for a minute. There's a couple of different methods of checking our implant. One is to use an instrument called a perio test. A perio test, if you've ever had that on your tooth, it taps, but it almost beats your tooth. I've had a perio test done to my teeth just so I would know what it feels like. And this one literally will beat your teeth. It almost makes you feel like it's going to break a tooth. And so a perio test will do a similar thing, but it creates a lot more and almost too much pressure on the tooth for me and for me personally to have. In using an AnyCheck is going to tap a couple of times, but it's not going to tap excessively. It's not going to apply a huge amount of pressure on there that the patient is going to need to worry about, or that you're going to have to warn the patient to, be ready for. And so it's a faster method of using. In using an ISQ reader, you have to come and remove the healing abutment. You have to place an AnyPeg into the implant. You have to have the appropriate AnyPeg for your implant that you have. The AnyPeg of the implant has to match the designer, the manufacturer of that. And so you can only use an AnyPeg a certain number of times before that needs to be replaced. And that gives you an ISQ reading. The AnyCheck can be used on any implant system to check with that, but it is ideal to be used with a Neobiotech implant to assure you that it is ready and prepared to be restored. A couple of things to use and to consider with this. The AnyCheck has to be close to parallel to the floor. And so typically I have my assistants set the patient up so that it will be parallel to the floor. From there, they make contact with the healing abutment, and then they're ready to take a reading. The range that you will receive in the digital readout will be somewhere between 30 and 85 are going to be the readings on that. It will also give you a different color. Right here you see that there is a green color here. The green color will show up if the reading is between 65 and 85. That green will turn yellow if the reading is between 60 and 64. And it will be red if the reading is between 30 to 59. What that tells you, the red means that it is not integrating. Yellow tells you it is integrating, but it's weak. The green tells you that it is integrating and healing well. For numbers to know, well, when would you consider splinting versus having a single or individual implant placed? In numbers that are lower than 70, you would consider you splinting or waiting a little bit longer for that implant numbers to come up. When the numbers of the AnyCheck are at 70 or above, you may consider using a single individual implant and not consider splinting at that point. And so in this particular scenario, here is a patient that has a fractured tooth in this bottom left area. This tooth is going to be removed and then an implant placed in that initial area and then also in front of and behind. And so when the tooth is removed and extracted, the bone is exposed and you can see the area where you would begin looking at placing implants into the immediate extraction socket, and then both mesial to that as well as distal to that tooth to have 3 implants that would be placed. Those implants are placed, and after they are placed and positioned appropriately, bone grafting of the extraction site is achieved and is accomplished. And as bone is placed there, AnyCheck readings can be taken. And then from there, you're looking at the finished product of where the implants have been placed. After that, the patient is back for the removal of sutures, and an AnyCheck reading is taken. And from that AnyCheck reading, that it is 2 weeks, the numbers are still high enough that it's able to proceed with an impression. At that 2-week point, if your gum tissue is appropriate and you're pleased with where the position of that is or where that gum tissue is going to be, then at that point you may consider taking an impression there. And then however the length of time that it takes your lab to create your crowns for you and prosthesis is when you're ready to begin delivery. In this particular scenario, the lab was able to create crowns, and then from those abutments and crowns, the prosthesis was placed. And in 3 weeks, the final prosthesis was placed. At this point, gum tissue is still immature and it is still growing, but benefits of this with a good lab are able to have the gum tissue grow into and fit the final prosthesis that is being placed. And so you have 9 years later a scenario where you have a fixed prosthesis that was placed in the bottom left area that still is looking good and is healthy in that area. And so in looking at considering, would you make a change in the mandible, which you might say, well, there's better bone quality there versus the maxilla. Again, study shows that there is no statistical difference between placing an implant in the maxilla versus mandible and loading time. And so in looking at this for these implants, you may load and would continue to load at whatever time you would choose based upon the readings, gum tissue, and when the patient is ready to have a final prosthesis placed. in looking at short versus longer implants, is there a difference in them in total success? Study also would show and indicate that there is not a difference between placing a shorter implant or placing a longer implant. There is still statistical significance that would show that placement of a short or long implant is going to have still a high percentage of success rate with this. And so as we consider this particular scenario where now we have the implant that is placed and we have been able to change our design of our implant, let's look a little more at the surface technology. This technology today versus previous is now to the point that we have an SLA surface that is added to our implant. This is present with the majority of implants. This is a technology that has happened with the majority of implant systems that are out there today. What that does, and I'll show you, by doing or placing this SLA active surface, is that it changes the bone growth in the secondary bone that happens. By changing that secondary bone growth to enhance or to increase the amount of bone, the speed of bone growth onto the SLA surface, that by itself has changed our stability dip. That stability dip has now been moved from the average of about 3 weeks to now the stability dip is about 1.5 weeks to 2 weeks. There still is a stability dip, even if you just apply an SLA surface to your implant. And so taking that surface onto a Neobiotech implant has created or changed from the RBM surface, which previously we have been using with implants, to now using an SLA surface of etching and preparing that implant itself. We now have a scenario where we have an implant surface that is able to integrate faster and is able to have bone growth faster onto the bone and implant interface area. And by having a faster integration of this implant and bone growth, we're enhancing or encouraging our bone to grow faster to our implant and integrate our implant faster. So now we have an ideal osteotomy that's been created. We have an ideal thread design, and we have an ideal surface that is being placed on our implants. With the combination of that, rather than having bone loss, there are studies that are showing that this particular implant not only can maintain the bone height, but it can also increase bone or have bone growth around the margin of the implant to the average of about 0.3 millimeter growth of bone around our implant. And with 1,000 implants that were placed and then measured, the mean average growth of bone was 0.3 millimeter of bone growth around our implant. So our scenario that's happened over the last 40 years is this. We've gone from, with Dr. Albrechtsen as well as Dr. Brandemark, that's saying, well, you're going to have about 2 to 4 millimeters worth of bone loss around your implant as you place that, to now we're having bone growth. In other words, our implants are not only advantageous to creating a prosthesis that we're replacing teeth, but we're actually able getting to the point where we're saying we're going to have and cause bone growth on our implants itself and around our implants. That is a revolutionary thought and a revolutionary point that these implants and combination of everything with the CMI fixation process has been able to create. And so with that, I appreciate you and your patience. I apologize again for my internet that happened, but would choose to open up, and I'm going to stop sharing my screen now and go back to any questions that would be there, and see if you have any questions. Let me come and pull up the question and answer box there, that if you colleagues would happen to have any questions, please feel free to type them in, and I'd be happy to consider them and to help with that at this point. So if there's any questions that you have, please let me know, either through the chat box or the Q&A area for that. I am grateful for your attendance. I'm grateful for your patience with us, or with me, and I'm grateful for the opportunity to present to you today. This is, like I said, is a process that I not only believe in, but this is a process that I am currently using, and a process that's going to be used on me shortly as I look at an implant area where I am going to now have an implant that will be placed in my mouth. And this is the reason that I would choose this particular implant system, because it is far above, in my opinion, the other implant systems that are presently on the market or that are currently available for us.
Dr. Platt,
And so
I
I
think
am
we
not
have
seeing,
question.
Shin, any questions that are coming. Do you have any questions, Shin, that you have received?
Well, yes. Dr. Michael Eng says, any comments on osteodensification for osteotomy? But if you think it's too broad, you can ask back.
All right, if there are no questions, then I'm going to turn it back over to our presenter to have access. And so I'm going to discontinue this component, or this portion, and I will turn it back to you.
Okay, thank you. Thank you very much for your lecture, Dr. Platt, and please stay connected with Neobiotech social media to communicate with us more. Search Neobiotech Global Department on Facebook or Neobiotech on YouTube. Please click follow, like, and subscribe to get more updated news. This lecture will be uploaded in our website, so you can review this lecture later at any time. For the next upcoming webinar, it will be on 15th, which is next Wednesday, or late night on Tuesday for American region. Dr. Manuel Fragrino from Mexico will be with us. If you have any questions or need more information, please email us to either bees@neobiotech.com or gabriel.lee@neobiotech.com. And we have more information in our website and social network service as YouTube and Facebook. And we are very happy to take your opinion on today's webinar. And let me briefly start the survey. And if you see, there's a screen popped up on your screen or your phones, and I would like to share a minute for us. We have 5 questions only, and thank you very much for your attention. And thank you all for being with us tonight, and thank you, Dr. Platt, again for your presentation. We'll see you in next week. Have a great night. I'll leave the survey page open a couple more minutes for you to finish. Thank you and bye.